Hello there and welcome back. Tony Meekum. So today we're going to be talking about dental and craniofacial anomalies. Now if you look at your study guide, pay close attention to that because there are a lot of different syndromes and different conditions that we're going to cover here. So it may behoove you to go back and review a lot of these. These are abbreviations used. If you look in your study guide, you also appreciate that I have a more thorough list of abbreviations so you can refer to that. As I said, these are just the dental anomalies, and there's a lot of them. And so I do go pretty quickly. I feel like dentists get pretty good at identifying these. A lot of it is just kind of identifying things that look altered with the teeth. As we see, there are things that affect number of teeth, the size of teeth, then a lot of different altered morphology of teeth. And then at the end, we'll get to these acquired abnormalities. But I imagine a lot of these you're probably already familiar with just from being a little bit in clinic, exposed to different dentists. So I also included in this lecture craniofacial anomalies, which you'll see there are quite a few of those. A few of them I've already covered, so that does limit this section a little bit, but let's get going. So supernumerary teeth, you're probably familiar with that. Other synonyms are hypodontia, mesiodens, distodens, peridens are specific types of supernumerary teeth. So mesiodens when it's usually in the midline of the maxilla, distodens posterior to a third molar, so it looks like a fourth molar, and then peridens when it's in the premolar region. And those are the kind of common locations, as we mentioned here. You see this is pretty common, so sometimes it'll block eruption of other teeth, may resorb other teeth, so you do need to look for it. In some cases they don't need to be extracted, so kind of like a third molar. In some cases they can be left alone, but in other cases you're worried about its effect on other teeth. Differential diagnosis, we did mention when someone has a plethora of supernumerary tooth, think cleidocranial dysplasia, perhaps Gardner's. Pycnodysostosис, that's these images here. This is a rare syndrome characterized by osteosclerosis and short stature. And in general, just remember, these are more common in Asian, Native American, indigenous populations, but it's so common you're going to see it across different races. And so primarily it's just identifying these. And as a dentist, you'll be pretty quick to recognize when there's a supernumerary tooth. What I see often is with 3D imaging, sometimes there's a mesiodens, a maxillary central supernumerary tooth that's no one's seen. It doesn't show up well on pano or other radiographs, and you can see it really well on CBCT. So keep that in mind. All right, then what about missing teeth? We call it hypodontia when it's only missing 1 through 5, oligodontia if it's greater than 5, and then anodontia when they're missing all their teeth, which is really rare. Missing some teeth is actually pretty common. Most common is to be missing the third molars, then mandibular premolars, and then the maxillary lateral incisors, and then mandibular and centrals. When you see a lot of missing teeth, think this one, ectodermal dysplasia. That's what we see right here. Features a lot of missing teeth, kind of conical shaped teeth. We see that in these images as well. They also have kind of specific, very thin, friable hair. They don't have sweat glands, so they're heat susceptible. And this is also more common in Asian, Native American, and indigenous populations. So again, just to reiterate, you see a lot of missing teeth, conical shaped teeth. First thing that should come to mind is ectodermal dysplasia. All right, and then macrodontia, macro meaning big, so enlarged teeth, greater mesiodistal crown width versus the contralateral tooth. Where do we see that in this case? And here we see both the clinical photo as well as the panoramic. Look at this premolar. It almost looks like a deciduous molar. It's a lot wider. And so we have these larger mesiodistal width premolars compared to the surrounding teeth. So those are macrodonts. I showed you an example of this when someone had an underlying hemangioma, which can cause the teeth to grow large. But this is bilateral and more of just a developmental condition. And then what about microdontia? More common in the lateral incisors, third molars. This can be associated with certain conditions, pituitary dwarfism, congenital heart disease. Progeria is an extremely rare genetic disorder where someone has symptoms of aging manifested at a very early age. And so these are just typical examples of microdonts. Sometimes the third molars are microdonts. A lot of times supernumerary teeth are microdonts. So you'll see these as well. Peg-shaped lateral incisors is not uncommon. And then what's transposition? This is just altering position of teeth. Sometimes it occurs with hypodontia or supernumerary teeth. Sometimes it's just impacted teeth, and then one erupts in the wrong location. Which one do you see in this radiograph? Well, it looks a little odd. Well, there's a premolar right here in the canine position, so teeth 5 and 6 are swapped positions. And as we saw, that's the most common location. Other premolars can also be transposed, and then the incisors. All right, and then fusion. This is fusion of two tooth germs. More common in the anterior teeth and deciduous teeth, although it can occur in permanent teeth. Here we see it's occurring in both. The deciduous teeth, looks like these teeth are merging. So how do you tell this from the next one we're going to talk about is gemination? If it's fusing into one, you should count the teeth. The teeth numbers should be reduced by 1. And so here we have a canine And if you count this as one, there's only 3 incisors. And so that's a central and a lateral incisor fused into one. And the same thing is happening with the permanent teeth below. And so that makes it fusion compared with gemination, which can look just the same. Gemination meaning twinning, where a tooth bud attempts to divide. And now let's count the teeth. So this is our kind of difficult in the mixed dentition, but here's the deciduous canine. This is just kind of hard to tell because a lot of these teeth are erupted, but this is one lateral incisor that's twinning into 2 different ones. So the tooth bud attempting to divide. For this one, if you count the teeth, the tooth count stays normal because usually it doesn't completely separate and create a whole new tooth. So you just have one tooth dividing into 2. Concrescent is just what it's called when roots are joined by cementum. This can occur just because of space restriction, trauma, occlusal force, or sometimes infection can contribute to it. True concrescence occurs during early development and acquired occurs later. So surgical caution. When you're extracting a tooth like this, it could be really difficult because if they're bridged by cementum, those teeth are going to be fused together. All right, quiz on this one after what we've just talked about. Is this fusion, concrescence, or gemination? The tip here was what? Count the teeth. Do we have an extra tooth or are we missing a tooth or is it the right number of teeth? Well, look at our canine here. Hopefully you can recognize the morphology of the canine. And these are our central incisors, 24, 25. So this is just one tooth. It's splitting into one. So if you count the teeth, the tooth count remains the same. So the answer is gemination. It is the expected number of teeth, so the tooth is twinning. As a little aside here, if you ever wondered why cats can't become dentists, this is why. And taurodontism, this is just an elongated tooth body with short roots. It occurs more in molars. The big thing that stands out to me is the elongated pulp chamber, as you see here. Usually it should kind of constrict as you get canals that come apical to the pulp chamber. But the pulp chamber is really elongated. The tooth trunk is elongated. And so this can happen with some frequency. There are a couple conditions it could be associated with: hypophosphatemia, trisomy 21. And typically there's nothing you need to do about these. It's just a altered morphology of tooth. And now dilaceration is just what it's called when a tooth is developing and the root tends to bend for whatever reason. Maybe something's developing around it, or it could be related to trauma in some cases. Most common, it's going to happen in the premolars, the maxillary premolars. Potentially it could block eruption of that tooth. And mostly what you're going to see is you can actually see the bend in the tooth where it bends distally or mesially, but sometimes it's going to bend buccally or lingually and come toward you. And in that case, you might see a target-shaped entity right at the apex of the tooth as that apex is bending toward where the radiographs come out. And that's why we have this target-shaped thing up here to remind you. And now you got to be familiar with dens invaginatus, dens indente, and dilated odontome. I think of these as just increasing severity of enamel infolding or sometimes cementum infolding. When it originates at the cingulum, it's called dens invaginatus. When it originates at the incisal edge, that's dens indente. And sometimes it may involve the pulp, so these are susceptible to periapical inflammation. When it involves the root, it may include Hertwig's epithelial root sheath. And so this can occur in the crowns or in the roots of teeth. And so in contrast with the coronal type, if it's a radicular type, it's going to be lined with cementum. So are you able to name these anomalies based on that description? Well, where's this one? It's starting at the incisal edge. It's fairly severe. It's including the pulp. That's probably our dens indente. This is a less severe one, just originating at the cingulum. That's a dens invaginatus. And then this is the one they call a dilated odontome when it involves the root and really expansile, almost looks like an odontoma. But you can see it's originating from the root of that tooth. See how you did. Dens indente, dens invaginatus, dilated odontome. And then in contrast with dens invaginatus, we have dens evaginatus, sometimes called Leong's premolar. This is just an outpouching of enamel. Occurs more common in the premolars and then the molars. The most common place you'll see this is mandibular premolars. And so this tubercle of enamel, you got to remember, as enamel grows, dentin starts to grow with it, and there may be a pulp horn underneath. So if you're doing a restoration on these teeth, if you're having to grind it down for the patient's occlusion, or it may just happen naturally with attrition, that enamel outpouching tends to wear down and that pulp horn could get infected. So it is prone to infection after wear or removal. You got to be careful with these. In some cases, what you'll see is looks like maybe a virgin tooth or not heavily treated tooth, and you don't really have a reason for a periapical lesion. This happens especially in Asian women, but keep that in mind. It could be a case of previous dens evaginatus, and maybe there's a pulp horn here that's exposed to the oral environment that caused that pulpal necrosis. All right, this is a good one to know, especially for boards. Amelogenesis imperfecta. This is a gene mutation affecting enamel. There's a lot of different types of these. I would say just be able to recognize kind of the primary types, especially type 1, hypoplastic, where they have really thin enamel. The enamel is normal density, but they start to have this kind of picket fence appearance. These are all type 1 Amelogenesis imperfecta, where the enamel's present, but it's just really thin. Clinically, the teeth may appear yellow, brownish. They'll appear square like this. And then type 2 is hypomaturation, where it does have normal thickness of enamel, but it's low density. So in the radiograph, it might appear more similar to dentin. And then clinically, these are going to look like snow-capped teeth. All right, and then type 3, probably the most severe one. That's the lowest density enamel, where the enamel just fractures away. That leads to a very pronounced tooth wear. So if you see teeth where the crowns are worn almost to the gums, that's probably going to be your type 3. Clinically, it's going to stain very dark, but somehow they're not very carious. And then type 4 is hypomaturation, so like your type 2, but including taurodontism. The differential diagnosis for Amelogenesis imperfecta is going to be with Dentinogenesis imperfecta, which we'll cover next, but DI tends to have bulbous crowns and narrow roots. Management of these, of course, are going to need quite a bit of restorations for aesthetics as well as function. And so can you guess what type these are? You see the unerupted succedaneous teeth where the enamel's the same shade as the dentin. That might make you start thinking type 2. But what about the wear of the primary teeth? Wears down all the way to the gum level. We say that's probably more the severe one, type 3, or your hypomineralization, hypocalcification. So that's what we're seeing there. What about this one? You see how the teeth are kind of square in shape? And pull up my magnifier here. They do have a thin layer of enamel that's normal in density. That's your typical type 1 hypoplastic. That one definitely be able to recognize. All right, are you able to recognize each of these? There's one where I said snow-capped appearance of the crowns of teeth. It almost looks like fluorosis of the teeth. But this is one of the types of Amelogenesis imperfecta. This is type 2, the hypomaturation. And then what about in A and B? Hopefully you appreciate the picket fence appearance, very thin enamel. That's our type 1 hypoplastic. And then when it's really worn down, looks the most severe, very dark stain. That's your hypocalcification or hypomineralization type 3. And then this is a pretty rare syndrome. Some people argue it's the same disease process as AI. And by the way, when I say AI, I mean Amelogenesis imperfecta. And so this is a syndrome where teeth resemble Amelogenesis imperfecta, as you can see with kind of relatively thin enamel here. Maybe in this case, they have the snow-capped teeth. But they also have taurodontism and associated with that steel wool hair, so similar to ectodermal dysplasia, osteosclerosis, and brittle nails. Here's a picture of Einstein in fuzzy slippers for no reason whatsoever, because why not? All right, now getting to the Mr. Glass picture here. Why do I have an image of Mr. Glass? Well, osteogenesis imperfecta is the disease that he had. In fact, during my skeletal muscular lecture, I themed the whole lecture after Mr. Glass, so we'll revisit this later. But let's focus on the dentinogenesis part, because that's what has to do with this lecture. Also called hereditary opalescent dentin. Clinically, these have an amber translucency. They can appear yellow to bluish gray. They can have enamel fractures, but what really stands out about these is the bulbous crowns, the constriction of the cervices. Almost looks like someone had a waistband, a belt, and pulled tight around the cervix of these teeth. And a lot of times the roots look kind of narrow and long just because they're so skinny. This one doesn't have that much change to the roots, but you can really appreciate the crowns. And then management for these teeth is pretty tough. They can be fairly compromised because of the effect on the roots, and so overdenture is preferred. Try to avoid extracting ages 5 to 15. Then as far as osteogenesis imperfecta, like I said, we'll cover that in another lecture. Just know that's the brittle bone disease where the patients have multiple fractures associated with blue sclera. And about 1 in 4 cases have dentinogenesis imperfecta with the osteogenesis imperfecta. I think in the movie Mr. Glass, they try to portray that by discoloring his teeth a little bit. As you can see, it doesn't look like real opalescent dentin. That's what it would look like in real life. But hey, for your casual fan, who's going to know the difference, right? All right, let's get to dentin dysplasia, which will resemble DI, or Dentinogenesis imperfecta. There are 2 different types, radicular or coronal. Radicular has short W-shaped roots. The pulp fills before eruption, may have half-moon pulp, and a lot of these teeth will have rarefying osteitis or periapical lesions with them. And so what does this one look like right here? That has that W-shaped root, some rarefying osteitis with a lot of these teeth. That's your typical type 1 radicular dentin dysplasia. And this also shows those W-shaped roots. So this is the radicular type. And then your type 2, your coronal, is more going to affect the pulp. And the pulp chamber starts to look flame-shaped. A lot of cases it doesn't show here, but they'll start to have pulp stones. And so your differential is Dentinogenesis imperfecta, but it doesn't really have that constricted cervix, bulbous crown appearance like Dentinogenesis imperfecta. Either it has a very distinct root appearance for the radicular, or more a change in the pulp space that you're going to expect for the coronal type. So quizzing you here, which is the one, whether Dentinogenesis imperfecta or dentin dysplasia, I want you to tell me type 1 or 2. Which one of these has bulbous crowns? Hopefully you remember that. That's our Mr. Glass one. Or Dentinogenesis imperfecta. Which one had really narrow roots? It didn't show it so much in our example, but I mentioned a lot of times these have narrow roots. That's also Dentinogenesis imperfecta. And then your thistle or flame-shaped pulp, probably one of the dentin dysplasia, right? That was the coronal one, or the type 2. Which one has normal root outlines as opposed to the W-shaped root? So which one doesn't affect roots? That's the coronal, or your type 2. And so your W-shaped roots, sometimes those roots are so small they're almost non-existent. That was your type 1 dentin dysplasia, or radicular type. And then rarefying osteitis in about 1 out of 5 teeth, even though they're non-carious, that was also your radicular or your type 1 dentin dysplasia. All right, so hopefully now you're able to identify these. Let me zoom in on each of these. This one does have those narrow, almost looks elongated roots. See the cervical constriction, bulbous crowns. What's that one? Keep that in mind as I go over here. This one, you see the pulp stones in here? So it's kind of changing the shape of the pulps, but the root outlines look relatively normal. That's one of our dentin dysplasias. I said when it affects the pulp, that's more your type 2, your coronal. Then this one over here are W-shaped roots, periapical hypodensities or periapical lesions on teeth, even though they're not carious. That's our radicular one, or type 1. DI, good. That should have been an easy one. Okay, good. Coronal dentin dysplasia. And then our radicular type 1 dentin dysplasia for that one.